Hi everyone, I'm Professor Sarah Rankin and I'd like to welcome you to Imperial's COVID-19 lockdown lessons. Today is lesson 12 and sadly the last of our lockdown lessons. We are joined today by Dr. James Kinross, and he has been a doctor working on the front line in hospitals in West London during lockdown. Before lockdown, James had established a collaboration with Microsoft HoloLens, which is a telemedicine technology that he's going to tell us about this technology, but also he's going to tell us how during lockdown he has used this technology to help protect patients and staff from risk of transmission of COVID-19 in hospitals. But before that, James, I would like to ask you about going to medical school, because I understand you studied medicine at Imperial, at St Mary's Medical School, and I'd like to know, how hard was it for you getting into medical school?
Thanks, Sarah, for the kind offer to come and speak today. Getting into medical school for me was not easy, and it was certainly something that took me some time. So I suppose things are a little bit different now, but when I was at school, I was unique, I suppose, amongst my peers in that I had one foot in the artist camp and one foot in the scientist camp. I really did like painting, and I was doing an art A-level. And I did chemistry, art and biology, which I'm not sure you'd be allowed to do now today, actually. But I suffered a little bit because I was quite dyslexic, and I was diagnosed with that whilst I was at school. And it was felt by the people that ran my course that I probably wouldn't be a good fit for medical school, and I wasn't going to get in. So I was recommended by my school not to apply to medical school, but I ignored them and I applied anyway. I was given an offer by St Mary's, which I was extremely grateful for, and I really wanted to come here. But I unfortunately didn't get the chemistry requirement that was needed, so I had to have a second go at it. And I managed to get through that, and then I was finally accepted to medical school, and I haven't really looked back since.
Great. That's, I mean, it's really interesting you say about being dyslexic, because I'm actually dyslexic. Well, I'm sort of a bit complex. I'd say I was neurodiverse. I'm dyslexic, dyspraxic, ADHD. I sort of tick all the boxes. So yeah, complete mix. Yeah. And certainly my experiences of school again weren't totally joyful, shall we say. Yeah. And again, like yourself, I think a lot of people that are neurodiverse, or whatever, however you want to call it, I prefer that term to the sort of disability label myself, because clearly, like yourself, I've managed to have a very successful career. And actually, you were mentioning about being creative. I myself am creative. Here we have me wearing one of my creations that I have made during lockdown. And so I think, but that creative thinking is so critical for science, and sort of pushing the boundaries. And, you know, innovation comes from not just being intelligent and knowing stuff, it's about thinking about new applications. And I think actually we're probably going to hear something of that today, how you've sort of looked at a technology and thinking, how could I use that in a different way, maybe in, you know, given different situations. And I think that's a real strength of people that are neurodiverse. It's been proven that they have different ways of thinking, being able to sort of think outside the box, problem solve. And I don't know if you're aware, James, but GCHQ have always been very positive about dyslexic people, and actually 25% of the GCHQ staff are dyslexic, and that's because they are fantastic problem solvers. So I think in that context, if we think about science, you know, it's great. And I really encourage, you know, if you are listening to this and, you know, you are dyslexic, dyspraxic or whatever, you may not be coming top of your class in terms of grades, because what you're being assessed for and the way you're being assessed in school isn't assessing your strengths. So I would really seriously encourage you to, you know, persevere and become a scientist, because you can become a great scientist. You know, Steve Jobs, Stephen Hawkins, dyslexic, so fantastic scientists, obviously. Anyway, moving on. Sorry, that's just me on my hobby horse, as you can see. Right, moving on, James. Let's get back to telemedicine.
Sure. So, I mean, just to sort of, before I go into that, I would just echo everything that you've just said, which is that really creative thinking is a bit of a superpower. And it was something I was very embarrassed about for quite a long period of time, because, of course, sometimes science teaches you to think in one way, and actually thinking differently is a unique thing. And maybe this is a really good example of it. So, just to tell you a little bit more about myself, I'm a surgeon, and I'm actually a surgeon who specialises in bowel cancer. And my group has been working on different ways to image anatomy during surgery, and that's how we got involved in this project. But to give you a little bit more context, when COVID-19 happened, of course, it affected lots of people who were unlucky enough to contract the disease and to get COVID-19, and it created significant problems in the hospital's ability to respond to that. But we knew that we had to look after all of our patients that did not have COVID-19, and that means patients with cancer, for example, but also lots of other chronic diseases, and surgery is still the primary treatment for cancer. And so on the basis of that, we set up an initiative, and we call that PanSurg. And PanSurg really was a plan to try and think about all of the non-COVID problems that were going to come when you completely turn a healthcare system around on its head in a week, to focus on solving a big problem. So we were able to do that because I work in this amazing department, and it's full of really smart people. And suddenly all of the work that they were typically doing based in cancer and other surgical specialties stopped. And we were able to repurpose them to trying to solve some of the big problems that we had in delivering surgical services through the pandemic. And one of the things that we set up was a program to educate and to teach, because we had to teach people how to manage COVID patients having surgery very quickly. And we knew that we needed to understand the problem in a lot of detail. So we set up some projects to measure what was happening. And then the third strategy was to innovate, because we knew that the problems that we had were big and we weren't going to be able to solve them simply doing what we did before. And in fact, actually, performing research in a health crisis is quite difficult. You have to find new ways to innovate and new ways to trial and to test. And it creates its own sets of challenges, and I'll explain a little bit more of those. But if you're interested, you can go to pansurg.org, and all of the studies that we're doing are there, and all of the data that we're producing is there, and you can learn a little bit about the work that I'm going to tell you about today. So before we get into I suppose the project, you need to understand a little bit about what mixed reality is and why it's important. So telemedicine is really the process of using a digital platform to communicate with a patient about their healthcare problem. And there are lots of different platforms out there. And to be honest with you, although we wouldn't typically advocate the use of Zoom for security reasons, you might as well use Zoom if you simply want to have a conversation. In fact, having a conversation by telephone is quite effective. But mixed reality gives you a very specific set of advantages. Now, mixed reality sits on a spectrum. It sits on a spectrum between virtual reality, which is a completely immersive world which you sort of step into, and many of you will have games consoles that you probably use at home that apply virtual reality, and augmented reality. And augmented reality is where you project a virtual image into the real world so that you can have a shared experience of that virtual object, and it's contextualized in the world that you're inhabiting with someone else. So that's got a certain set of uses. Mixed reality implies that you can interact with those augmented reality objects. So you can do things with them, you can manipulate them, you can change them in some way. So in this example, you can see two people wearing headsets, and they're seeing what is actually a 3D rendering of someone's MRI scan that's been reconstructed, and they can look at any slice that they want in that MRI scan, and they can both see that image in one place at one time, and they can use it. So mixed reality is a technology that has quite a lot of applications in surgery. Now, there are a number of different headsets out there that do this, and at the moment, because it's quite a difficult thing to do, we work with a number of different technology providers, and in this case, Microsoft. And Microsoft have made a number of different headsets. They've made 2 of them, and this is their second iteration, and it's called the HoloLens 2 system. Now, just to be clear, I don't get paid by Microsoft. Oh, I don't know why that skipped. I don't get paid by Microsoft, and I'm not funded by them. So I just probably should declare that. Now, this is a computer that you wear on your head. It's a holographic computer, and at the back of the headset, you've got that's where the computing bit lies, and it's got its battery pack in it. And the important thing that you can see is there's no wires there, which means it's untethered. It means that you can walk around and you're not connected to a machine. And then you've got a visor at the front end, and I'll explain a little bit more about that. So this is my friend Louis. Louis is a physician, which means he's a clever doctor, and he works with us on our surgical wards here at Imperial, and he's been helping us with some of the work, and you'll see his picture again. So you'll see on the front of Louis's head, he's got a couple of sensors. I don't know if you can see my mouse, but he's got a couple of sensors on the side of the headset, and then there's a little camera at the front there. Now, those sensors do something very similar to the type of sensor you might see on an Xbox One. So an Xbox, if any of you guys are gamers, you will know that an Xbox allows you to capture images about the real world. It allows you to sense the real world and create a very high definition render of the real world around you. And in fact, it can do things like detect hand signals. So the device is quite clever, because when you walk into a room, it will take a 3D render of the room around you, and it will remember that room and everything in it, and it will orientate itself within those 3 dimensions. And that's useful because you can then, if you know where you are in space and time, you can then start to project those images into that 3D render, and you can start to see them, and you can start to interact with them. So the technology is really part of the general evolution of computing. So many of you will have what was now rather quaintly referred to as a personal computer. I'm sure all of you are users of laptops, for example. And this is really computing power for the masses, but it's generally immobile, and it has no contextual awareness. So you use the desktop, and it doesn't really know where it is in the world. Now, of course, smartphones have changed everything, and all of you will also, I'm sure, have a smartphone which you will use to look at your favorite social media channels or to message your friends and family. And that really, for my generation anyway, is a supercomputer in your pocket, really, and it has a lot of computing power within it, and it's on the go. And it does have some contextual awareness. So your smartphone will have a series of really quite sophisticated sensors that will tell you a lot of information about the world that you're existing in, and of course information about you. Mixed reality sort of is the next step beyond that, really. So it was what's sometimes referred to as computing power at the edge, and what it does is it blends the real world, the physical world, with the digital world, and it allows you to interact with that information and to visualize and to see that information. Now, of course, mixed reality has lots of applications. It's not just used in healthcare. In fact, healthcare is really a secondary use care for the original technology that was really designed to be used in industry. So within the headset, there's some quite clever engineering. And within the eyepiece, it's kind of like a heads-up display set on a fighter jet, except wherever you look, the image, that 3-dimensional render is projected onto your eye. So you see it as if it was there, and it will track, and it will move, and it will move with you. And I'm sure Microsoft, have invested many hundreds of millions of dollars in inventing this proprietary technology. There are a number of different other companies out there that do it, and you, I'm sure, are familiar with other kind of headsets. So this iteration of the headset is an advance on the old one, because you get a slightly broader field of view. I don't know how you can measure comfort, but apparently you can. And this headset's quite comfortable, which is quite important if you're a surgeon, because you might have to wear these headsets for quite a long period of time. In fact, actually, during COVID, we had to wear them for quite some period of time. And the important thing about it, if you're a developer, is that there's an open framework there, so you can go into that headset and you can develop lots of applications for it. So I'm just going to give you some examples of how we were using this before COVID. So what you can see here in these two scans are MRI images. These are MRI images, unfortunately, of someone who has cancer, and they have cancer of the bowel. And what we've done as a part of our treatment for bowel cancer is quite often to give something called chemoradiotherapy, which is basically chemotherapy that is a medicine with radiotherapy, which destroys those cancer tissues. Now you can see, and you'll have to take my word for it, on the image that's scrolling through there, you can see on your left a horrible cancer. And when we look at that cancer after chemoradiotherapy on the screen on your right, that cancer melts away. It becomes quite difficult to see. And that's a problem when you're operating, because you don't know where the cancer was, yet the definition of how you operate is really defined by the original cancer. So that's a problem. So one of the things that, the two questions we have is, can we properly remove it, and can I cure it? And what is the correct anatomical plane for dissection? So we set about trying to solve that problem using mixed reality technology. Now, just to warn you, there might be some gory operation pictures coming up. So if you're of a faint disposition, just bear that in mind. So this is not gory. So what we've done here is we've taken those same MRI scans and we've created a three-dimensional picture. And what you can see here in that video is someone wearing a headset, looking at that image projected onto one of my amazing nursing colleagues, who very gamely laid down for us so that we could demonstrate it. And so we're both seeing the same anatomical position image presented into a real person in real time. And you can see all of the complex anatomy that you need to see. And one of our MSc students designed a bit of code so that a laser beam comes out of my head. So we all know that we're looking at the same place at the same time. And then we can have a discussion about the anatomy that we're looking at. And I can manipulate that little blue arrow that you can see there is me, and might just tweak the position of that anatomy so that I can move it precisely where I need it to be so that it's overlaid exactly where I need it to be overlaid during the operation. Now, this is a demonstration application, and we would use this possibly for planning an operation in due course. And you can see some of the important anatomy there. So I've just labeled some of that for you. So you can see the yellow stuff is the bladder. CRM means circumferential resection margin. This is the plane where I know I've got to be sure that I remove all of the tumor. And you can see some of the really important arteries and veins and nerves that I need to remove that I need to protect and avoid once I'm performing the operation. The green bit is part of the spread of the cancer called EMVI, which I need to remove. And here's us using it in practice. So that's my anaesthetist about to put a block in so that we were going to numb the patient during the surgery. Here is a different use case. So this time it's a patient that's had a traffic injury. They've been injured and they've broken their leg, and they've got a really nasty fracture of their leg. And we need to reconstruct the limb, and they have to have something called a myocutaneous flap, which means we take skin, muscle, and some blood supply, and we have to put it over the bone that's broken. Now, typically, when you do that in surgery, the surgeon has to use an ultrasound probe, and you can just see in figure the top right-hand corner here. That's what the surgeon is doing. They've got an ultrasound probe, and they're listening for the sound of the blood flow through the artery so that they can find the right artery, and then they can reconstruct the limb. The image in the middle is a CT angiogram. So that's a type of CT scan where we just bring out the blood vessels that we're really interested in. And this special one, what we've done is we've marked those blood vessels using a piece of software, and then we've rendered it in 3 dimensions, and then we've dropped it into the HoloLens. What that means is that when you're in the operation, and we'll see if this video will play, I hope it's not too loud. You hear the surgeon this is what the surgeon sees, and they are manipulating the image so it overlays precisely where they are going to make their cut. And you can see they're doing that importantly without having to touch anything. So that's really important when you're scrubbed, because when you're scrubbed you can't type on a computer keyboard, and you can't use a mouse, and you can't interact with the machine. But of course, when you're scrubbed using the HoloLens, you can do everything without having to de-sterilize yourself. So what we found was that when we did this is that surgeons really liked it, because instead of having to use an ultrasound probe, which might take them 30, 45 minutes, actually they could do this in a couple of minutes, and we've saved huge amounts of time in the operation. And actually within about 5 or 6 cases, they just abandoned using ultrasound and completely moved over to using this technology. So that's what we were doing until COVID happened. And then COVID happened and everything changed. It changed overnight. Now, just to sort of give you some reference point, infections are a big problem in the National Health Service. So about 300,000 patients a year acquire an infection because they come into hospital and they get that bug whilst they're an inpatient. And infection rates are quite high, and in surgery that's a big problem for us, because if you get an infected wound, that makes you sick, and we really want to avoid it. So infection control is a big deal for us. And we were kind of aware of this problem for some time. So surgeons wear masks for this reason. You can see a patient, sorry, you can see someone wearing a mask and someone just breathing out normally, and you can see the airflow that comes out of their mask is significantly reduced, even with a simple mask. So we were really aware about infection rates before COVID happened. But COVID did change everything. This is information from June. This has now subsequently been updated. And this is a picture of the hospital I took walking home in the middle of the crisis. So we were really busy at St Mary's during the height of this, and the trust had a lot of really sick patients. We had 143 ventilated patients by the beginning of June. We sadly lost a lot of people. That was 417 people that died. That number has climbed, sadly. And by the beginning of June, it was 881 patients that had recovered. It's now nearer about 1,300. So overnight, our hospital became inundated with large numbers of very, very seriously unwell people with COVID. And the biggest problem that we had at the beginning of March and the beginning of April was that we had to protect our staff and keep them safe, because if our staff get sick, we can't look after people. And if you can't look after people, then the sick people will not get better. Globally, the access to something called PPE, which is personal protective equipment, which is the face masks and the gowns and the gloves that you wear, became a massive problem, because the COVID crisis just meant that all of the products that we needed were rapidly consumed. And it's crazy to think that globally we're currently using 1 billion face masks a day, every single day, which is a huge number of masks. Now, that creates its own sets of problems, not least of all sustainability and environmental protection, but also productivity is a big problem. Like, you've got to sustainably produce those masks, and at the moment we just can't produce them fast enough. And the problem is that healthcare workers were not being educated on how to use them properly, and they couldn't access them. And a large number of healthcare workers globally have been severely affected. And that immediately became a problem for us. Within the second week of March, I'd lost about half of my surgical team to sickness. So we'd lost a very large number of our team. And within the United Kingdom, this information is some United Kingdom specific data on COVID-19 and healthcare infection rates. Nearly a third of all infected cases by the beginning of April were calculated to be from NHS healthcare workers. So we have very, very high rates. And in fact, actually, when you look at the data, a very large number of patients have died. We've lost over 100 healthcare workers in the United Kingdom, and we lost 4 from this hospital. This is a picture made up of all the healthcare workers that have died looking after patients with COVID-19 during this healthcare crisis. And it's a really frighteningly large number. So whilst this all happened towards the end of March, we got a phone call from Microsoft, and they said, James, we know you're doing some HoloLens research. Can we help? What could we do with the HoloLens 2 system? And we were quite skeptical initially. We weren't sure what value it was going to have for us. And we knew that we couldn't introduce this technology in a kind of standard way. We couldn't just introduce it to the ward and to run a trial, because there was no time. So we had to take on quite an iterative approach to applying this technology. And the first thing that we did was we went out and we asked our colleagues on the front line, do you think this has a role and could it be useful? And the first place we went to was intensive care, because the problem that we had was that we had a lot of surgeons being repurposed to go to intensive care who didn't know necessarily or were not trained to deliver care in that environment. And we knew that we had a large number of patients that had to be cared for under isolation. And we thought that might be quite useful. And intensive care doctors came back and said, you know what, actually, we're okay. We don't think it's going to be that helpful. So then we went down and we continued speaking to people. And we ended up speaking to are physicians who were caring for patients on COVID wards. So all patients with COVID were kept on wards where they could be isolated and protected. So these were patients who didn't require ventilation, but they were pretty sick. And the problem that we had on COVID wards was that we would typically send in ward rounds of doctors, and ward rounds of doctors might contain anything up to 8 doctors, or it might be as few as 3 doctors. But typically they go and they do a ward round of a team of specialists. And every time a doctor goes into a ward, they have to wear the appropriate gown and gloves, and then they have to enter that ward in their team. And every time they go from patient to patient, they have to change their gown and their gloves and consume more and more PPE which we just didn't have. And we thought that maybe mixed reality might have a role. And one of the major reasons we thought it might have a role is because there is a camera on the front of that headset, and that camera allows you to have a first-person view of what that doctor is seeing. And you can share that view with a team of doctors that can be discreetly located elsewhere. Now, in this image, you can see Louis, who's one of those doctors that I said, wearing that headset on a COVID ward. And what's interesting about here in this picture is important to me for a really simple reason. And that's because the doctor is using this technology, and I'll explain in more detail what he's doing with this in a second, but he's still able to be at the patient's bedside. He's still able to look at the patient in the eye, and he's still able to communicate with that patient in a kind of humane, empathic way. The patient knows that the doctor is at their bedside, even though the way that their care is being delivered is changing. Similarly, you can see it in this picture. This kind of gives you some idea. You have to be very flexible with these technologies. It's not a case of simply standing in one location. Our jobs are really busy, and quite often, particularly, we are dashing between operating rooms, intensive care units, and the wards. And this technology, because it's not tethered, it comes with us wherever we go. Now, the first use case really was to separate out the team of doctors from the doctor going to the COVID environment. And what you can see here is the team of doctors that would typically be with Louis on his ward round. The X-ray that doctor there, Guy, is looking at is of a patient with awful COVID lung disease. The poor patient was extremely unwell. If you've ever seen a chest X-ray, that is very abnormal. And these doctors here are all watching this ward round happening live, and they're making decisions, and they're communicating with Louis in the first person, and they are engaged in a kind of real-time telemedicine activity, really. And this is what it looks like in reality. I'll let the sound play, and hopefully you'll be able to hear that.
Okay, and the next patient is B1.
Yeah. So the next gentleman is a 61-year-old male who's admitted as a major trauma call. He's had unstable T6 and T7 column fractures which have been surgically managed. He's got rib fractures which are being conservatively managed. His current issues at the moment are that he's COVID-19 positive and he's got significant pain secondary to the rib fractures which are limiting his ability to take deep breaths.
Okay, and do you have his latest bloods after the fixation for me?
Yeah. So they're just appearing on the screen now.
So his hemoglobin's actually stayed quite stable, which is good after the procedure, and he hasn't got a dramatic rise in his platelet count. That's perfect. And you mentioned that he had some rib fractures and he's also COVID positive. Do you have recent imaging of his chest? So we can have a look at his on your.
Yeah, his chest X-ray is just coming up now.
Okay. Just pop that there. Okay. And that's been from a couple of days ago, and from our side, we obviously, he's from the end of the bed, he's comfortable, he's alert, there's no acute distress at all, and his observations, the last count by the nurses inform me they're actually fine, and he's off oxygen now. So he's clearly improving from that perspective, which is great.
So I think the main thing to say is that we had permission from the patient to film that, and we had consent. You'll notice from that interaction a couple of really important things. The first thing is that that discussion happened in a two-way discussion where both the doctors could see each other, and it happened at the bedside. Now that's important because actually we can bring multiple doctors to the same bedside remotely. So in fact, you can have something called a multidisciplinary team meeting at the patient's bedside. And at the high point of the COVID crisis, we were making very difficult decisions about who to ventilate and who not to ventilate, who to palliate sometimes and who not to palliate. And sometimes those decisions are really tough, and you might need 4 or 5 doctors to help make that decision. And in fact, we could do that remotely with everybody joining the call, getting really good eyes on target and understanding the problem and having that discussion in real time. The second thing you probably noticed is that when Louis was interacting with that digital information, he didn't touch anything. And that's really important in COVID, because COVID, we know, is transmitted by touch. That's why you wash your hands and you wear gloves. And actually, we think that significantly plays a role in reducing the risk of infection transmission. And the third thing is you could see he could access all of the information that he needed through the electronic healthcare record during that ward round. So it wasn't just the communication with the doctor that was important. He could leverage the information that he needed to make critical decision making, and he could do that just through wearing the headset. So you know, what we were excited about, and this is a picture of Guy Martin and Philip Pratt, who did a lot of this work, was not just that it had a good clinical impact. It's that our junior colleagues or our training colleagues using this technology felt that it really improved their ability to communicate with the sickest patients. So we asked everybody in a questionnaire before and after the study that we ran over about 5 weeks, over 5 different clinical environments, whether or not they felt it helped, and it did. And the reason it did is because if you're a junior doctor on a ward round, quite often you're stuck at the back, and particularly in COVID-19 environments where these patients were isolated, they couldn't get into the room and access and see these patients because one doctor would go in at a time, because it just took so long to put on and take off your PPE. And this way they could really get a very good understanding of what was happening, and they felt that it allowed them to care for their patients more effectively. And we saw really significant changes in the way, in the amount of time that doctors were exposed to PPE, exposed to COVID-19, because basically fewer doctors were going into high-risk clinical environments. So we saw on average a saving around 50 hours per week per ward of potential COVID contact time where the HoloLens 2 system was used. So it had a really direct benefit. It was a simple application of a technology to solve a big problem, and it worked very effectively. Now, of course, it stands to reason that if you're using less doctors in high-risk spaces, you're also consuming less PPE. And that meant, in fact, in some wards, we were using up to about 700 items of PPE less per week per ward. So we significantly reduced our PPE burden. And you can see that in the box plots here. You can just see the time exposed to harm per day on this axis, and this is pre-HoloLens and post-HoloLens. And you can see the time reduction there. And you can see the same in the PPE reduction in the graph on the right. And it was interesting that our ward rounds also became much more efficient. We saved about 1/3 of the time on our ward round when we used the HoloLens system versus when we didn't. Now, what became immediately obvious to us afterwards is that if we could do that to deliver care, we could probably use it to deliver education. So the challenge, of course, at the moment with COVID is that we are not allowed to let our medical students into COVID environments, so they can't learn. And we also have to teach our surgeons how to get into the operating room, and we're not allowed to let them in because we don't have enough PPE at the moment still, even today. So we thought, well, could we leverage the same technology for the same purpose, which is to teach? And so we did. And about 2 weeks ago, we ran our first ever completely virtual HoloLens ward round with 3 groups of medical students in 4s watching one of our doctors do a ward round. Now, we've adjusted the HoloLens system here a little bit. You can see there's a camera, a microphone attached to Louis' head there. And the reason is that actually the Microsoft HoloLens 2 system has a very sophisticated noise cancelling headphone in it, which means that when someone is talking to you, only you can hear them, no one else can hear you. Now that's really great in a clinical environment because you want to have confidential discussions about patients and you don't want that information being disclosed. But if you're trying to teach, it's a problem because everybody has to be able to hear what's going on, including the patient. So we kind of got to work around through that system. And so then we started running teaching rounds. And this is an example of a teaching round. So again, this is a real patient on a real ward. You can see here the drug history that the patients are on, and you can see some of their imaging and their x-rays. And this slightly nonplussed patient sat there whilst medical students are asked questions about the case, and the teacher is able to guide them through the specific scenario. And of course, they can interact with and they can touch those virtual objects. In fact, they can draw on those virtual objects using augmented reality tools that are embedded within the software, and it works really quite well. In fact, I'm sorry about the quality of that slide. It doesn't. It's a little bit rough, so apologies about that. But they felt that just over 60% of the students that we surveyed felt that it enabled them to access clinical teaching that they otherwise could not have accessed because of COVID, because they're not getting onto the wards. And the majority of them really felt that it improved that they enjoyed the teaching and that it was of sufficient quality to be useful. So on the basis of that pilot, which directly came out of the COVID experience, we're now scaling that project. We now have about 30 HoloLens systems within the trust, and we're now deploying them on a much more ambitious scale to see if we can deliver bedside teaching going forward. And of course, they have significant roles outside of COVID, because we need to deliver and ensure that our medical students and trainees get access to a broad variety of clinical environments. And not everybody can get into an operating room. Not everyone can get into an intensive care bay. Not every hospital does, for example, complex pediatric surgery. And so this allows us to scale our education. This is my good friend and colleague Sanjay Perkayasa in the middle of an operation wearing a HoloLens system, where he's able to show what he's doing in the first-person viewpoint with a bunch of medical students who are located outside. And it brings up an interesting point, doesn't it, when you look at these two, because there's some obvious differences here. And we've coined this idea of the digital surgeon or the digital clinician. And the digital clinician, I think, is someone who's going to engage with these sorts of technologies as part of their educational strategy going forward. So now our work continues, and on the basis of that pilot work, we're now partnering with a number of different trusts across the country, about 6 in fact, and we're launching a more formal trial to see how this technology can be more safely and effectively deployed. What you can see there is one of our amazing nurses, and this was our International Nurses Day, and she was wearing a nurse's outfit from 100 years ago, and she's wearing a headset of today. And we think probably this technology has very significant applications outside of doctors wearing it, and we really want our allied healthcare professional colleagues to wear it, and we also really want to use this technology to help patients to improve the experience of care that they receive whilst they're in hospital, because sometimes it's really hard to explain things like operations and procedures and tests, and we think that this technology might be really, really helpful. Now, lots of people did this work, and I want to thank Guy Martin, and I want to thank Philip Pratt, and also Microsoft for helping us and supporting us with this work. And these are some cards and messages that were sent to us on our COVID ward that we put up and we get to look at every day. And we're very grateful for all the kind messages and messages of support. And you can just see in the top corner there the clinical team that were on the ward during the time with us. And I'd be delighted to answer any questions any of you may have. I'll stop sharing my screen, shall I? Hopefully that will work now. Yeah,
thank you, James. That is really impressive. And I think you've shown real sort of out of the box thinking there, true dyslexic thinking. Yeah, so I'm just thinking, I wonder if we can also apply that sort of technology if we're trying to teach practical classes, science practical classes remotely as well. That would be interesting to investigate that and think how that might be.
Yeah, and I think we're really excited about its potential. I think one of the interesting things about COVID in general, and you will all be aware of this in all of your walks of life, is that it has pushed digital type technologies forward, and we've made rapid advances in a very short period of time. Interestingly, we could only really use HoloLens 2 because the NHS adopted Teams, which is another Microsoft product that we're speaking over today. And it meant that actually the leap between using Teams and using HoloLens 2 was actually not a giant leap for a lot of the clinicians that use the technology. And I think you're going to see the same thing in all walks of education and teaching and training, not just in healthcare. And so we've had a number of different discussions with our scientific partners at Imperial about using this sort of approach for teaching even fundamental practices of being in the laboratory, for example, or for safety training, or for safety practicalities. And we're not even beginning to leverage the full potential of this technology, because remember, this headset carries within it a very sophisticated array of sensors which can measure the world around it. So it might be that actually you can use this to teach not just knowledge or behavior, but you might be able to use this to teach more sort of technical tasks or practical skill sets that you can't do with other kind of media. So we think it has very significant application in that role. Yeah.
Yeah, I think it's incredible, and I know for somebody that's dyslexic, I like to sort of learn by seeing and doing. So I think actually again that's why, you know, something this is much more sort of speaks to me much more than anything that would be written down. So yeah, it's interesting. So I first came across this sort of telemedicine, and I don't know whether it was HoloLens or another similar technology that they were using in war zones, and that I don't know if it's something that was developed originally for the military, but it was the idea that you could have somebody that maybe, you know, in wherever, not near a hospital, that had been injured, that needed a specific operation, and you would have your surgeon back in the UK or wherever they were, being able to see the actual patient and the injury of that patient, and being able to guide somebody that had sort of basic surgery sort of techniques, but wasn't obviously the expert in that area, and could therefore sort of guide them doing specific procedures and operations sort of thousands of miles away. So yeah, I think, and if you think about that, then that means again that sort of technology you could apply to sort of other developing countries and help people. I know, for example, in terms of you know, when people unfortunately stand on landmines and have their you know, lose limbs, that sort of amputation surgery, which we're very good at. You know, we've sort of perfected in the West, that skill set could then be transferred to those surgeons. So yeah, huge numbers of applications, and yeah, really exciting.
Yeah. So we used it. I mean, so we've been funded by the military to develop similar applications for them, and in fact we use this technology in our trauma team. So we are, St Mary's is a regional trauma centre. So there's 3 in London and we are 1. So our trauma teams are actually already trialling this technology. So when you're performing a complex surgical procedure, like for example, having to make a cut in someone's chest in a life-saving emergency procedure, when you're performing that procedure, actually you can project all of the information that you need into the operating field so you can see it. So when you're really stressed and you're really having to think very quickly, you get that sort of real-time support and communication in your ear from your peers who can see what you're doing and help you and train you. So we think it's absolutely got a role. And just the other thing to say is that of course the military have been looking at these technologies for some time. The US military have actually developed an application for this particular headset that will measure temperature. So when you look at someone, it will immediately take their temperature and report that back to you. Now that's kind of important in a pandemic, of course, but it kind of gives you a flavour of how you might leverage some of the real potential of these sorts of technologies.
Yeah, and I mean, we've been hearing from other groups at Imperial how they're also sort of developing technologies. I mean, we heard from PanSurg in electrical engineering how they've made this sort of basically lab on a chip. And so they have a lab on a chip technology. They can they've adapted that to be able to test for COVID-19 within 20 minutes from a sample. So you can imagine when you start combining these technologies, the power. And then many of the talks that we've had, we've been talking about big data and, you know, all the sort of computing technology that can again enhance our sort of reading of the sort of basic data and science and things like that. So yeah, I think yeah, it's entering a new sort of era, isn't it? And I like the idea of the sort of digital doctor. Yeah, it really just amazing. And I know there's another tool that you know, we haven't really got time to talk about, but you know, you're also using the iKnife, which is another incredible sort of technology that has been developed, and that is like a surgical knife, but it has it's linked up to very sophisticated science, so mass spectrometry, which allows, when the surgeon is cutting through tissue, it can differentiate between normal tissue and cancerous tissue, and that's really important as a surgeon when you're trying to just cut out the cancerous tissue. I mean, I'm probably saying it way too simplistically there, but
no,
you know, we haven't got time. Anyway.
I think it is important to say just a couple of things, though. The first is that if you imagine if COVID-19 had happened maybe 50 years ago, you know, even that more recently, I think the impact would have been significantly worse. And our ability to innovate at pace, I think, will have saved millions of lives, actually. The second thing to say is that I think a major issue in a lot of these translational technologies is data visualization and data engagement. So when you've got these amazing, huge, unbelievably complicated data sets, you've got to find new ways to work with them. And I think these sorts of technologies will have a really big role. And the third thing to say is that a lot of technologies, much like this, have been repurposed. So to take the iKnife, for example, which is exactly as you describe it, typically when you cut tissue with a knife, you create smoke, and we take that smoke and we analyze it in chemistry. Well, we can detect viruses with the same technology. So we've been able to repurpose that technology to solve the problems that we've got today. And I think, you know, in many ways, this has been a crisis. Well, it has definitely been a crisis, but positive things will come out of it.
I think you're absolutely right. I mean, yeah, we have come up with some amazing solutions to this crisis. And I think the other thing is, I mean, in these talks, we're looking at it from Imperial's perspective, but this is a global thing that's going on at global level. And as scientists, we're also discussing this at a global level through our webinars. We're sharing all the sort of new breakthroughs and technologies, etc., with our colleagues in other countries. And this is why, again, having the technology to be able to do that and not have to all fly to a different place to have a meeting is allowing us again to sort of move science forward that much faster. So it's really exciting times for us as scientists, and hopefully we will sort of continue that momentum, and hopefully that, you know, governments and public will understand, you know, why it's important for, you know, for us to do this science and move things forward. Anyway, Margarita, you've got some questions from people, so please, go ahead.
Great, thank you, Sarah. There are a lot of questions. I'm going to start with the basic ones.
Great.
So, is the use of mixed reality technology expensive?
So the answer is sort of, and it's going to get a lot cheaper. So I don't know if you can see this sort of headset here is a kind of top of the range headset. It's quite sophisticated, probably costs in the region of around £3,000. But that price is going to come down because it's the Ferrari of headsets, and you probably don't need it. And you don't necessarily always need to wear a headset. So there's a lot of mixed reality technologies which you can use on your mobile phone, and that's much cheaper. It's definitely scalable. So at the Cleveland Clinic in America, which is a big American hospital, all of their undergraduate medical students now get a HoloLens system when they come to the university, and they teach all of their anatomy via the mixed reality platform. So I think you're going to see it come down to the cost, you know, of a fairly sort of standard mobile phone type price, and I think it will maybe even cheaper.
Wow,
that's great, because one of our listeners is quite worried about the cost, and he's asking, how is the already financially struggling NHS going to be able to roll this technology out on a large scale?
So that's a really important question, and it's a question we're trying to answer through our research, because the cost of the headset might be £3,000, but if you're saving a lot of money by the fact that you're not consuming a lot of PPE, and if you're saving a lot of healthcare costs by making your clinical care much more efficient, or by improving the outcome of your patients, the cost of £3,000 for a headset might in fact be very cheap, and it might in fact save you an awful lot more money. So, you know, we know that demonstrating economic value for the NHS is one of the most important things that we have to do, and we think that ultimately it will be economically viable. But that really depends specifically on the use case. And of course, the problem for us is that COVID-19, which was our original use case, we really hope is going to go away. Like, we want that to be over, and we will have to demonstrate the economic value for other use cases as we work with it.
But also, it's the sort of green credentials of it as well, isn't it? Yeah. If you're reducing the amount of PPE, because what you were saying at the beginning, the sort of numbers of face masks being used per day, just, you know, that's going to lead to some sort of great sort of landmass. Correct,
and it already is. So we need sustainable, reusable technologies. Absolutely.
That's cool. Do physicians need special training or expertise to use mixed reality technology?
So we give everybody, as we're onboarding to the platform, a short introduction. It takes about 15 minutes to get used to the interface. So you use the device by hand signals and by communicating or talking, but actually it's very intuitive. So the answer is not really. It doesn't take very much to get used to it. But there is a bigger question there, which is, how do we teach doctors or medics of the future to get the most out of digital technologies and the data that comes from them? And I do think we need to think about that a little bit more carefully. And you're seeing the evolution of undergraduate curricula to support doctors of the future in their ability to kind of get the most out of it. So I definitely do think that we need to equip our young doctors better to be able to use it more effectively.
Yeah, I just wonder how much you're going to have to do that, in the sense that, you know, you've been referencing Xbox and things like that. So, you know, you've got a lot of young doctors coming with that sort of expertise, and you know, wouldn't this make a great game? I'm not into Xbox because I don't like the types of game. You know, I'm not into racing cars or running around, you know, killing people. So, but you know, if I had this as a headset and been able to do sort of mock surgery and see if my patient survives or not, depending on, you know, whether I sort of cut an artery or something by accident, or whether I did the right procedure or the right tests, you know, this would make a fantastic game, wouldn't it?
Well, we're interested in serious games and games for therapy, and we ran a hackathon about 18 months, 2 years ago with Microsoft and the HoloLens system. And actually some of our medical students came up with games for teaching children with cystic fibrosis how to do their respiratory physiotherapy. One of my favorite games was, there were two ones that really stuck out. One was a game where you had to blow virtual clouds across the room. So of course, if your lungs don't work because you have cystic fibrosis, it's important that you breathe deeply and that we measure your lung physiology as you're doing it. And the second one was you were a dragon and you had to breathe fire. So actually, you can use this technology in extremely imaginative ways and really apply gamification and game theory to absolutely.
Yeah, and that comes back to our sort of thing about innovation and creativity. So yeah, get going. Great. Next one, Margarita.
Yes. How available would you think mixed reality would be to universities in the future? I think it refers to the medical school.
Well, it's available now, so very available. I mean, of course, it's not really a question of availability. It's a question of cost and it's a question of whether or not you want to really invest in that as a platform. So the issue really, in fact, is not hardware, it's software and having practical applications and a digital curriculum that can get the best out of it. So Imperial, we're really progressive. We have a completely digitized undergraduate education, and we have an entire digital education group that is thinking about how we can use these sorts of technologies to improve generally the quality of education that we deliver. And then I think it becomes very powerful, very scalable and very usable. You have to remember this is a young technology, really. I mean, the first headsets that we have only really came to the market around 5 years ago. And so the challenge at the moment is building out the software, building out the tools that you can properly use with this software to get the most out of it. And I think that's going to be the thing that changes.
Yeah, I think it's really important to say, you know, as Imperial, we're obviously a STEM university. We're all about science, technology, etc. And so even though we're incorporating that into our scientific research, but we're also thinking about that in terms of our education, because we all like to be sort of educating people in sort of interesting and innovative ways as well. And we've, you know, as James is saying, for lots of our things now, we're sort of going beyond the classroom and thinking of different ways of teaching and interacting with people to make it more fun and more sort of authentic, I guess. Right, Margarita?
Yeah, 2 more questions. So I like this one. It has to do with interaction between doctors and patients. Do you think that if the interaction using a HoloLens will be totally digital, will influence the quality of services provided by physicians?
A really, really good question. And the answer is at the moment we don't know. But what we do know is that patient experience is extremely important. We want patients that come to our hospital not just to get great care and have a great outcome, but to have a good experience of care. And that means that we have to think quite carefully about how we communicate and how we engage with patients to make sure that they feel like they are in control of their care journey and that they are we're properly partnering with them to make them better. And I think we can definitely leverage these tools to do that better. But of course, a lot of that is actually about more fundamental ways through which we communicate and which we think about these things and which we prioritize them. So at Imperial, we actually have a patient experience unit led by Professor Helen Ward, where we actually are trying to understand these things in a really structured way and almost develop a science around it. And I think these technologies have an important part to play, but I think they're part of a bigger strategy to help solve some of those problems.
Yeah, that's really important in healthcare management. So the last but not the least question, how far will the use of advanced technology, such as these HoloLens, be able to make surgery more effective and improve public health, especially when we have to deal with increasing populations and huge number of patients?
Well, another brilliant question. So the answer is that in surgery, in global surgery, you know, we have 5 billion people on this planet that don't have access to safe surgery every day, right? So that means, you know, 1 billion people don't even have access to simple things like pulse oximeters, so how we measure oxygen in your blood. So we have to sort of put this stuff into context. And of course, technology should be equitable, scalable, and they must be improving generally the quality of surgery. So they have to truly democratize. And I think this technology has a specific series of applications in that sense, because it really allows remote access educational support, proctoring and training. So if one headset is deployed in a field hospital in a remote part of the world, actually you can bring to bear specific surgical expertise and specialities into the operating room environment. It may improve the precision and accuracy of the treatment that we deliver by improving the safety of that operation and the visualization of those anatomical structures. So we think that's going to be important, and that's been one of the things that we've been looking at in our laboratory. But again, I come back to the point that I made earlier. This is quite a new technology, and we're really just beginning to fully understand where the value of it lies. And actually, we haven't even seen the first full-scale trials happen yet. But we're really hopeful that Imperial will lead those trials, and at the moment, we're trying to set them up.
Great. So is that all the questions now, Margarita?
Yes, I don't have any more questions.
Thank you for all of your amazing questions.
Brilliant.
Indeed.
So yeah, thanks guys for all your questions, and thank you James really for answering them and in joining us today, giving us an insight into how the HoloLens technology can enhance medical practice and indeed the education of medical students. So as this is the last in our series of lockdown lessons, I'd like to say a special thank you to Margarita, who has been here for all the lessons, acting as moderators for the Q&As, and also to Sam, who has been behind the scenes producing all these sessions. They will all be live and you're able to watch them on YouTube shortly. So if you've missed any of the previous ones, please have a look. And thank you all for joining us for these sessions. Please fill in the survey that's in the chat and tell us what you thought about this lesson. I'd like to now extend a personal thank you to all the scientists and clinicians who have clearly been working really hard throughout lockdown, but have also made time to present their work to us. Personally, I've been totally inspired by how they have come together to create teams that have worked in incredibly short space of time to address a range of problems that arose as a result of the pandemic. That was whether it was initial modelling of the spread of virus in the UK that led to the lockdown, to making thousands of litres of hand sanitisers, creating quick, cheap, reliable test systems, or designing new ventilators, undertaking experiments to understand how this virus works and how it affects the immune system or changes individual cells, to identify medicines that could be repurposed to treat infected patients and running the clinical trials to establish their efficacy, and then to being involved, as we've heard today, in changing the health system and in treatment of patients during this very difficult time, and not least to those that are continuously seeking to generate the first vaccine. So we have heard not only how virologists, but clinical scientists, immunologists, pharmacologists, molecular biologists have been involved in these projects. But perhaps more surprising, we've also heard how chemical engineers, bioengineers and electrical engineers have also applied their expertise to solve some of these problems. Moreover, we have also seen the power of these interdisciplinary teams of scientists working together and the application of these sort of really innovative technologies. You've heard from many young scientists who are the people that are actually doing the work on the ground, either as clinicians or in the labs during lockdown. And you've heard about some of their backstories. So we've heard how many of them have changed from one field of science to another before finding the type of science that they really enjoy. And in the light of the Black Lives Matter movement that has been prominent in the last months, I'm really heartened that what we have seen firsthand is the diversity of young scientists and clinicians working at Imperial, which bodes well for the future, particularly as I know that there are many in the scientific community that are really active in promoting equality and diversity in science. I have to say that at this time, I'm really personally really proud to be part of Imperial College London and the global scientific community. I think the response to the pandemic has showcased some of the best in science in terms of working collaboratively to find creative solutions incredibly quickly. I hope these lockdown lessons have inspired you to think about having a career in science or as a clinician, because we need to ensure that we have the next generation of scientists and clinicians ready to solve the next global problems and going forward, and whether that be the next pandemic, the climate crisis, ensuring the health of our aging population, or inventing the next generation of technologies. So it just leaves me to say good luck in your future endeavours and goodbye for now.